Wanda Crocker. I am the Director of Provider Relations, and I am one of your co-hosts for today. Carrie Williams, the TCM TAC lead for the division, is a co-facilitator. So if something goes wrong with my system, she can pick up and take away. Um, as you can see from our agenda today, if I can make it move, we have a packed agenda, lots of awesome information, lots of updates. So I'm glad everyone is here. So we are going to go ahead and get right started right now with Miss Jennifer O'Day, the Assistant Director at the Raleigh Satellite Office, and she's going to talk to us about reporting events after hours.
Thank you, Wanda. Can everyone hear me? Can you guys hear me?
Yes, I hear you, Jennifer.
Thank you. Okay, so there has been a recent change to the TCM agreement, and some TCMs have chosen to have initial after-hours responses come to the regional office. And so we wanted to just kind of update what needs to be reported to the regional office. And I will preface this with saying that you should talk with your own TCM entity to see if they have relinquished this duty to the regional office or if they're going to keep it, because the majority of the TCMs in the Raleigh region are agreeing to keep the calls coming to them. So it will vary from county to county. However, what needs to be reported immediately to our after hours on call? So every regional office has an after hours on call, and there are basically six issues that need to be reported immediately to that after hours on call. The first one is any deaths. That is considered a critical event. And so the DMH requirements have not changed, and those are outlined in the Division Directive 4.070, as well as the DOOR 4.270. And it's also trained on the Relias platform on reportable events. So any death needs to be reported immediately. And so during business hours, those need to be reported via event report. But if it's after business hours, then you'll need to contact the after hours on call. Other critical events, which critical events are defined as an incident involving department services, facilities, or consumers that are to be reported to key department administration locally and in central office. So the Relias training provides training on incidents that shall be classified as critical events for community-based providers. In addition to deaths, any serious injury to a consumer, and serious injury is one that involves hospitalization. So if the person is not being admitted from a serious injury to the hospital, that can be reported on an event report and does not need to be called into the after hours. All complaints and allegations or suspicions of abuse, neglect, misuse of funds and property are to be reported immediately to the DMHDD after hours. Any suicide attempts resulting in an injury, and it says in the reportable category 6 that if there's a realistic threat or physical action or serious self-harm or assault to others, and the injury is above minor first aid, it is a critical event and must immediately be reported to DD. Elopement with law enforcement contacted or involved. And again, in DD reportable category 3, it is a critical event when the DD law enforcement is involved because a consumer leaves a support service program, residence, activity, unsupervised, or unnoticed by staff, and staff is unable to maintain the consumer's approved level of supervision or the approved supervision level of the other consumers in service. And that's what defines it as a critical event. And then last is, or not last, the second to last is criminal activity reported to law enforcement involving a consumer as the perpetrator or victim when the activity occurs at a facility And again, that's under category 3, and it rises to the level of a felony. Then it is critical and must be reported immediately to the division. And then fire, theft, or any natural disaster resulting in extensive property damage, loss, or disruption of service. And again, under category 4, it rises to the level of extensive property damage. Then it is critical and must be reported immediately to the Division of DD. So I would suggest you all work with your local support coordination entity, find out um, if they are going to be using the regional office as their first line to contact. And then we will then need to have a number that we can contact the TCM, because we need to be able to communicate to you all and get information from you all. So it's kind of a twofold kind of action. Is there any questions, Wanda, that you can think of, or have I covered everything?
I think you covered everything, and we're gonna do Q&A and post those, Jennifer.
Okay.
Just wanted to highlight what you said. We may have providers who work in multiple counties, and one county you work with may be utilizing the regional offices, their call, and others don't. So it's really a county by county, TCM by TCM agency decision. So providers, you really need to know what's going on so you can have your staff at the appropriate locations know who to call when you meet these criteria. So you might have to do a little digging.
That's all I have, Wanda. Thank you.
Thank you so much, Jennifer. Appreciate you coming on and doing that for us. All right. So next, I have a massive list of information to go over for technical for providers and support coordinators alike. So I'm sure you might have additional questions from going through these slides. Hopefully I will answer most of what you have. So with the implementation of the 7/122 provider contract, we implemented a provider notice portal. So this portal is an electronic system through which the contractor notifies the division of decisions to decline or terminate services as outlined in their POS contract. 3.34 and 3.35. 3.34 is speaking to when the provider declines to provide the service within 10 calendar days after the service authorization. 3.35 is related to when the provider is giving 30 days notice. The portal does not substitute for the provider notifying the individual, their guardian, and the service coordinator. This is the method for you to notify the department. The provider notice portal is on our division website. And it's not going to let me click on that. But when you go to our, let's see, I wanted to be able to show you where to find it. And I give you an illustration of how it works. And of course, it's thinking, which might be why the link didn't work. And so service providers, you go to information for service providers, and it's right here in orange, provider notice portal. It is super user friendly. You do have to enter specific information, so we have enough information to know where to route the notice. And you just follow the cues, your demographics, what kind of services are you providing? There might be more than one. So we have ISL, group home, shared living, non-residential, both ISL and non-residential, both group home and non-residential, and both shared living and non-residential, because you might be providing services for multiple services for the same person. Of course, we need to know who you're providing notice on and what region you're serving them in, so that the information can be routed to the right regional office.
Wanda,
Yes.
your screen is not showing what you're what you're wanting to show
Okay.
is not showing.
Of course it isn't. My link didn't go live as I'd hoped it would, so let's do this. It should be sharing. Can you see now the portal information?
No.
Darn it, I don't know why it's not pulling that up. Okay, so, but anyway, so that you know, it is super user friendly. That link is provided. Hopefully, if you copy and paste that into the website, it will take you directly to this portal. But there is a
Wanda?
series, yes.
We're seeing your, yeah, we're not seeing the PowerPoints.
Right,
bring it
right. I'm gonna switch back. Unfortunately, it is, I don't know what happened.
Just exit out of, there you go.
There we go. So it is super user friendly. Drop down boxes leads you through every single data point that you need to know. It is for all services that are giving notice. So if you are a therapeutic service provider and you're giving notice that you can no longer serve that person, you would record that here. If you're a rehabilitation provider and giving notice, you would record that here. Again, it is not a substitute for notifying the individual, their guardian, and the support coordinator. And you'll be prompted in the provider notice portal to remind you that it's not a supplement. In fact, it will ask you if you have notified those people. There's also a signature block at the end for whoever is filling out that notice, and you can do that electronically with your mouse. And so it's super simple. So my next update is on shared living. You might have heard that have some pending structure changes to shared living. They're super exciting, going to simplify how we do shared living today. We've already had one training on shared living with great attendance, lots of shared living providers. And we'll have two more coming up that I'll have the dates for here momentarily. But what I'm going to give you a high overview of what those changes are. You will need to come to the training to get the details and illustration of the form and how it's going to work. We are still pending CMS approval for these changes, but we wanted to increase people's awareness and explain how it's going to work before it goes live, so that people aren't scrambling after it goes live to figure out how it works. And it's super simple. I think you guys are really going to like it. So once we have CMS approval, urban versus rural will only apply to room and board. There'll be no differential in the residential service codes and rates. So, and it will only apply to room and board until we can convene a work group and do a study on what the room and board should look like. And then we hope to make that consistently one rate as well. The daily rate is based on 3 tiers that are predicated off of the person's rate allocation score. So you need 2 pieces of information. You need their rate allocation score, and you need to know whether they're urban versus rural. And the rate determination form we've designed is going to give you the answer as to what to authorize if you know those 2 pieces of information. The daily rate is all encompassing. It includes direct support, it includes the host, it includes relief, includes administrative costs and professional manager. I was asked on the first training whether or not the provider was required to pass all of the daily rate onto the host, and the answer to that is no, because it's all encompassing. They are the provider has to keep some of those funding for administrative costs and to fund the professional manager and the relief staff that are necessary. Since it is all encompassing, there is no more relief variance reporting. The amount of relief provided will be between the host and the administering agency and the planning team to determine what's really necessary and to make that happen for the person and for the host. When we get this approved, It will follow the same default process for budget structure as we do for ISL or group home. So that was really awesome. So we will be able to bring them in as a default tier 1 until the RAS is provided through the MOS, and then we will retro implement the correct tier to the start or implementation date. It will also move up and down as with renewed RAS and MOS, just like it does now for ISL and group homes. So we'll get a lot more consistency, right? We'll be able to have that same process, and that's going to be really nice. Providers will no longer have to submit budgets for shared living. So that's a really key factor. I've mentioned a rate determination form. Support coordinators are going to use that, and it's going to tell them exactly what they need to authorize and the code they need to authorize. So it's going to be super slick. Again, you do need to know the person's RAS and whether they're herbal versus rural. And so as in all things rate related, there will be no rate reductions if a person's current budget is higher than the new rate structure. So they will retain the current or the higher of the two until such time perhaps a new RAS is completed, which increases the daily rate through the new standard process or rate structure. Or until the enhanced FMAP maintenance of effort ends. So it's consistent with all the other rate changes we've made. Another key note is we will no longer be doing individual waiver budget adjustments. The new structure is the consistent structure for all providers across the state. So there will be no individual budget adjustments. Providers will need to learn the new system and construct their system and their service in a way that fits within the daily rate established. So process, so you're aware, once we have approval, we've already pulled a report. We're already working on making sure it's accurate, and we're going to go back through and central office will modify the daily rates back to 7-1. And PR will then send a list to the shared living providers so they can see what was authorized and verify any issues, and we'll correct any errors found. So our next date for the shared living training, more in-depth, more detailed illustration of the rate determination form, is tomorrow at 9 a.m. and then August 24th at 10 a.m. We did it at 3 different sessions to maximize possible participation to fit within everyone's schedule. So if you're not already registered for one and you support shared living, whether a support coordinator or a provider, please make sure you register for one of those times. Although this does not have anything to do with the new rate structure, we do want to remind people, because there has been some misunderstanding, that out-of-home respite is now a certified service. Specifically, it will say out-of-home respite on the provider's certificate from licensure and certification. So a provider of shared living services can utilize vacant relief homes where no authorizations are present for host home services for out-of-home respite. But before they can do that, they have to get certified specifically for out-of-home respite. Their shared living contract does not carry over into the out-of-home respite service. So just so you don't freak out, if you're a group home provider who already does out-of-home respite, you're okay. At your next certification, we will amend your certification to add specifically out-of-home respite, but you were covered until then because you already had that service underneath the old system. But just wanted to remind people of that because there seems to be a little bit of confusion. We added this slide at the last moment, and I'm super glad that MARF members spoke up and said, hey, we need to talk about this and make sure people understand. So thank you for bringing those subjects to us that we need to cover. Dehabilitation clarification on staffing ratio and rates. The day habilitation service definition in our current waiver is 1 to 6. That is the expectation. That's the maximum expectation. There's some confusion because people are hearing, but the DayHab FY22 rate was built on a 1-to-1 ratio. And that's correct, it was. But there were things that we didn't catch with that. And so that is what we provided. That's what we proposed. That's what was budgeted. So that's what's being implemented. But we are staying true to the service definition ratio of 1 to 6. The actual staffing ratio at a day program is driven by the people's needs. So they might have some groups of 1 to 6. They might have some groups of 1 to 2. They might do some 1-to-1, but it is based on that person's need and what kind of staffing level is driven and outlined in that ISP. So we just want to provide that clarification. We are not expecting DayHab providers to all of a sudden provide one-on-one supports to every person at the day program, okay? So hopefully that offers some clarification. We do have a Mercer rate refresh underway for fiscal year 23. And that rate study will continue to support at least $15 per hour for DSPs. We will continue to work with stakeholders to achieve an accurate DayHab service rate for FY23. And in fact, we have a DD rate study stakeholder meeting tomorrow to present on the preliminary information we have. So we encourage you all to participate and hear about that, but it is an ongoing discovery, and we definitely will take all factors into account and work with our stakeholders to make sure we have everything identified. Okay, so hopefully that helps clear up some stressors for people. Provider waiver assurance. On our last couple of statewide provider meetings, we have talked about waiver assurances. And we've talked about the percentages that we're currently experiencing with provider staff qualifications and training. So I wanted to share with you a graph of the last basically 3 fiscal years worth of data and where we've sat. So this one specifically is related to staff training for certified and non-certified services. So you can see we've had a lot of months where we were above 87%. That is our threshold. Anything below 87%, we have to do a plan of correction with CMS and explain why. So in this assurance, you can see that 25% of the time we were below our 87, consistently below during this fiscal year. So that is very concerning, especially in combination with the other waiver assurances that apply to staff qualifications. So we'll look at this graph is specific to personal assistance and respite staff. And in this graph, we have a 50% of the last 3 fiscal years that were less than 87%. So we already are on a corrective action plan for this. As you can see, the last 2 quarters of this year were below the threshold, and we provide this information to CMS on a quarterly basis. So it does not matter whether at the end of the year we're above 87%. Each quarter counts. Each quarter's results counts, and we have to justify each quarter. And CMS starts asking some really difficult questions when you turn this data in. Besides our corrective action plan, they expect enhancement, and they ask the hard questions. They ask questions like, did you continue to pay that provider for that staff who wasn't qualified? What did you do about that staff that wasn't qualified to provide that service? So as our numbers continue to be lower than 87%, we are going to have to increase our efforts to be accurate. Every time a waiver assurance is below threshold, it puts our waiver at risk. It puts the individual's funding for services at risk because CMS funds 60%. So it's very important that we pay attention to what's going on and what our data is telling us. So one of our new strategies for addressing this is next month there will be 2 meetings with a focus group of service providers. These providers specifically were noted in the last 5 quarters, I believe, of not having 100% of their staff qualifications and training in place. That doesn't mean they're at 60%. They could have been missing one staff. Um, so, um, so they'll be meeting, and our intent is to talk with them and learn from them. What are the issues preventing success from staff being trained? One of the training issues that are consistently in the top 3 is staff not being trained on ISPs. It is consistently in the top 3, and that's probably one of the easiest ones for staff to get, because we're just looking for signatures on the plan that they've been trained, or some sort of system showing that they've been trained. But that is one of our top 3. So we'll also be working with those stakeholders to strategize for systemic improvement. How can we help them? What can we change? What can we do? Is there anything we can do? And that work group is being led by Amy Rutledge and Dawn Cochrans, who are both vendor service coordinators for the provider relations team. So they're really excited about getting to know you all and bringing that group together. And we're hoping that we can use that to problem solve and come up with more strategies to impact this. And of course, we're hoping with the new value-based payments, since so many of those are surrounding staff training, that with the value-based payment system, it will better support providers to get staff trained adequately and timely. So hopefully that will have an impact on our waiver assurance numbers as well. Rate allocation scores. You might remember at our very first statewide provider meeting that we talked about uploading rate allocation scores to CMOR. We are finally successful, mostly successful, because we've identified 477 people whose rate allocation did not transfer to CMOR. So we're currently working on those. We're going to have to manually look up their rate allocation score if they have one and get that transferred to CMOR. All providers and support coordinators with access to CMOR can find the information under the identifiers page in the individual's record in CMOR. So you look up a person you're supporting and you go to identifiers, which is where you would find their comprehensive slot number, their Medicaid number, their DMH number, and you will find a MAS-ROS or a CIS-ROS or both. So for this person, they have both a CIS and a MAS, so they're both recorded. Our intent was to only record the last CIS-ROS that they have, but some people have the last 2. If you don't see a MAS in CMOR, that means they haven't had one yet. So every MAS that has been conducted since July 1 of last year is recorded in CMOR. So what we were working on is getting the historical SIS-RAS in CMOR as well. So you should be able to see that now. We're working on using this information, since now it's consistently in CMOR, to pull reports into Tableau so that we can pull provider-based reports for your review, which right now, with it being in 2 different systems, it's very difficult to get consistency. This CIS-ROS, just so you know, has been converted to a 5 scale. Okay. So these are both, anything you see in there is on the current 5 scale rate allocation score. You shouldn't see any 6s or 7s in there. So disclaimer for these next few slides. I am not a tax accountant. I am not an advisor. And I don't know a lot about this subject, but I happened to recently be at a MARF meeting where their memberships had a great presentation from a consultant that they use, who talked with them about the CARES Act employee tax credit. And I'm like, wow, I wonder if the rest of our providers who aren't MARF members understand what is potentially out there that they might be able to access. So there's just a few slides here. Some providers might think that if they haven't already claimed it, they are no longer eligible, and that's not true. There's still an open window for application for credit during those fiscal years allowed. And you can still claim wages paid after June 30th of 2021 through January 1 of 2022. And you might have to do an adjusted employment tax return within the deadlines. The longer you wait, the more the quarters drop off. So that's the best of my understanding. Just more information. It was really phenomenal. I mean, my ears perked when their consultant said, we have helped providers get as many as, 6-figure breaks on their taxes. So it's phenomenal. If you have not looked into it, it's probably well worth your while to do so. And there's also the misconception that providers who received a loan through Paycheck Protection Plans wouldn't be eligible for this tax credit. And that's not true. You may still be eligible for this tax credit. Now, what little I know about this is it's not easy. If anybody does their own taxes, it's probably not easy, especially if you have business taxes, right? So, so you definitely want to consult with a tax accountant if you're interested in doing this. Do your research, seek consultation, see if if you qualify. I understand, like I said, the documentation is a little complicated. And I thought I would just throw out there because I know we have new providers who may not know what MARF is. So when I say that, it's Missouri Association for Rehabilitation Facilities, which really doesn't describe what MARF is and what they do, but it's a consortium, basically a membership of service providers and some targeted case managers who lead advocacy groups, who participate on our work groups, who advocate with legislature, and they collaborate together to share these kinds of resources. So I feel very fortunate that I just happened to be at that meeting to hear about this resource to share with the rest of you. So another resource for you, if you are not a MARF member, could be to reach out to a MARF member that you know, and maybe they could share with you, or to reach out to MARF themselves to explore membership options. If that's something you're interested in, there's lots of perks, including consultations like these from experts that can help providers figure out how to best utilize the resources that are out there that you might not be familiar with. So just saying, there are resources. PR will be sending out some more information to providers so that you can check out more details. This was just a really light overview of what's available out there, what you can find, but we'll send out the resources that we received from the MARF's consultant, and then you can review those and seek your own advisor, do your own research, whatever really meets your needs. Okay. I am done with my section, so I am going to turn it over to the Universal Design and Assistive Technology team, Holly Reif and Shelley Brown.
Good afternoon, everyone. So we're going to provide some UDAT updates for you today surrounding the health assessment and coordination services, assistive technology and remote supports, and some EAA. I'm going to start with our health. Wanda, are you driving? Oh, I see where I can drive up front. Thanks. I'm going to start with health assessment and coordination, which is HAC. Currently, our only provider of this service is StationMD, so you might have heard of it referred to as StationMD services. We have a new guideline that supports this service now. It's under guideline number 86 on our website. The guideline supports part of the uniqueness of the HAC services and outlines the two different ways to initiate the service. The first is by adding it to the ISP through the regular planning process, whether that's annually or through an update request. And the second is by the individual support staff or family directly contacting StationMD for the services. For those who directly call StationMD, a listing of those individuals is sent the following month to all TCM and support coordinators for authorization input. This allows the families and individuals to use the service at the time they need it instead of waiting for the service to begin. The authorization starts at the date of the initial call and ends with the individual's current plan year. The addendum in the guideline can be used for the utilization review process. Since HAC is a subscription service, it needs to be entered as a monthly authorization and should not only be input for the month of each contact. We have seen a growing number of authorizations that start in 1 month and run for 6 to 12 months, but only have 1 or 2 months with actual billable authorizations. So as an example, if an individual calls the authorization should start and with the initial call and end at the ISP year. So if their ISP lasts for 6 more months, there should be an authorization for each one of those 6 months. We also still have a large number of authorizations that were requested in December of 2021 that have not yet been entered, and we will be inputting these into IQMFD tracking system for follow-up and education efforts. Assistive technology. We have a great update about our education pilot that we have been working with in conjunction with our Technology First initiative. We had 22 support coordinators, self-directed specialists apply to be part of this pilot and have now completed their accreditation through SHIFT, which is a national technology education platform. Yesterday, we got to do our very first Technology Explorers meeting, and it was phenomenal. We had 23 participants submit questions and coaching topics prior to the meeting. David Baker was able to join us, who is part of MOAT, as our guest technology resource expert. And we had wonderful discussions about technology resources, how to get started with technology supports, and how to access funding or acquisition for needed technology. The next Technology Explorers meeting is September 21st, and any support coordinator who would like coaching around assistive technology, they just need to email their coaching question or topic to the UDAT team, which is Technology First and Universal Design at dmh.mo.gov, with the subject for exploration by 5 p.m. on Friday, September 16th. These coaching sessions are only for support coordinators and voc rehab counselors. We have had lots of frequently asked questions about assistive technology, so I wanted to take some time to go over some of what we've seen. Assistive technology is a natural concept in our daily lives. Our DMH-DD waiver service works the same. Individuals and support teams do not have to choose between using an assistive technology or having their in-person support. There's lots of places that could intersect using both supports, and those might include employment, medication support, applications for daily reminders or task support, and communication devices and applications. Please remember that assistive technology does not require a bid, a consultation, or an evaluation. We have had a lot of requests for equipment that's not part of the AT services too. But some of it is adaptive equipment and is available through our specialized medical equipment. This might be beds, lifts, or low-tech support options like built-up flatware or specialized plates or those really fun mats that keep your plate from moving around on you while you're trying to eat. If you have more questions about those, please check out our May UDAT Lunch and Learn recording, which was all about the difference between home modification, EAA, specialized medical equipment, SME, and assistive technology, AT. Another great resource for the difference between these three is on the DMH manual in the support coordination manual under section H. There are about 6 individuals across the state who are currently qualified to provide an AT consultation if your team feels like it's needed. So please reach out to us, but there's only 6. So there could be a line, but right now we have some space. The AT consultations are not part of the UDAT's EAA consultations that are required for projects over $5,000. The EAA consultation is to ensure project adherence and completion, reviewing the information concerning the OTPT eval, and if you missed the UDAT Lunch and Learn on August 9th, go check out the recording because Shelley and Chris do a great job walking through what the EAA consultation process is and how it works. Just a reminder, each aspect of the AT service definition code has its own modifier. And when I think about these modifiers, I think of them as the aspect's favorite little dress or jacket or tasteful pantsuit. So when you're working with the assistive technology codes, please make sure that the aspects have on their favorite outfit. And if you have any questions at all or any concerns about how to work the AT definitions, please just reach out to UDAT. So we are seeing some great growth in both assistive technology and remote supports. we want to continue and improve that growth. So I've been reaching out, trying to come up with 2 different community of practices. One for our community providers who would like to have some more discussions about implementing technology into their existing programs. So talking about what kind of roadblocks they might be facing, lessons learned that they've tried already, ideas for the future, and supporting those providers who are just getting started, as well as helping out the division figure out how to support the growth of the AT services and where we should go in the future with them. I'm also working on a similar community of practice for self-advocates to get their voices heard on what they would like to see with our assistive technologies and remote supports and our technology first initiative going forward. For remote supports, in general, cameras are not seen as remote supports, but surveillance. If an individual or individual's team truly believes that a camera is absolutely required for support, there are certain parameters that need to be in place prior to implementation. UDAT is not reviewing all remote supports. However, if any community provider is wanting to implement remote supports for the first time, please reach out to UDAT for assistance with policy, procedure, and to help with any facilitation for that camera division approval. Community providers will need division approval for camera-supported technologies and will also have a unique data collection requirement. Just remember, UDAT's here for you guys. We're happy to consult on any remote supports that are needed. And I'm going to kick it over to Shelley for our EAA update.
Okay, thanks. I have just a few quick things I wanted to review. One being that what Holly touched on just briefly is we do have some trainings that are coming up, as well as a recent one we had in regards to the EAA consultation process. And so that's available on the website if you want to review that from August 9th. And then next week, we have another one coming up on the OTPT evaluations. And that's going to be an opportunity for us to learn maybe how to interpret that, how to review those and use that in our outcomes, as well as what to expect. And this is also an opportunity for OTPTs to understand what our system may require and need from them as an OTPT evaluation. So be on the lookout for those, or here's the information if you need that to go ahead and register for that webinar. I also want to just use this opportunity to say thank you to everyone. We started this team about a year ago, and it was about December that we started some new processes with the consultation process of EAA. And so with that, we had the criteria established that anything over 5,000 that was in an EAA request would be reviewed by our team. And we started to track these numbers. And our first report, we were at 19%. And then the next month we moved up to 28%. And I can tell you now we're sitting anywhere between 90 and 100% of each month. And so we just really appreciate you guys getting us that information, because as a result of those reviews, it really does allow us to provide some more consistent messaging, to kind of see areas where we need to provide some more clarification, or maybe where we need to change the system. And we do use that information and we do use that feedback as for our own systems as well. This also allows us the opportunity to work with providers and service coordinators to ensure that the outcome is the best result for the family. And a lot of times this will even incorporate, we've been able to work with Ree and Lucas on some things and really make sure we have all the team players that need to be involved at the table. So that consultation piece is really designed to ensure that we give families the best outcome, individuals the best outcome that they can get. We also use that information, like I said, to review the structure for EAA. And then we also use that to determine where we need to have enhancements. And I think you're going to see that in the next couple months, there's going to be some changes coming to EAA. So stay tuned. I think they're going to be favorable changes. And this is something that's a result of the information we've been able to retrieve as a result of these consultations and working directly with EAA providers. Also want to give a thank you for the webinars. We've had some great attendance, and we just asked that you continue to give us feedback on information that you would like. And this also goes into, you know, we can do one-on-one trainings. We can work with, we've worked with service coordinator teams and just come in for their team meetings. Whatever is needed in any areas, we are more than happy to provide that. And then we also have a lot of referrals for just some one-on-one technical assistance. I know last week I worked with a provider who has an ISL, Because it's not provider owned or controlled, they're eligible for some home modification, and they were really just wanting to know what the process was and what we need to do. So those are things that you can look to us to. Maybe it's just a quick question. Maybe it's a planning question. How do we get started? So definitely don't hesitate to refer folks to us in any of those situations. The link below is just what I referred to as kind of our getting started document. If you have questions over our team, some of the services that we provide in that consultation or what those requirements are, feel free to click on that and that will take you to an overview of our system. And then of course, anytime you need to get in touch with us, we can be reached at the Technology First and Universal Design at dmh.mo.gov. And we will be able to respond to you directly with either your question or your consultation request. So I just wanted to use this opportunity to say thank you for the progress and the information that we've received so far, and to let you know that we definitely are using that. We're definitely seeing some progress, and we just encourage you guys to continue to use our team to make sure we can help you with those outcomes. So I will turn it over to Angie to start with the fiscal updates.
Hello, everyone. So I'm trying to adjust my screen here so I'm not all shaded out. But anyway, thank you so much. There's a lot of good information today. So excited to be a part of this. If we go to the next slide. Many of you have seen the new decision items, the budget actions, but there may have been someone out there that hasn't seen those. So we want to make sure to share this with everyone. I will start off by saying that this has been the most funding that I believe our division has received historically, at least to my knowledge. This last year was $755 million. So that is a lot of money. So we're so extremely thankful for that. All of you that are here today, we're really able to help tell the story of what you face daily with the data that you've provided through staff stability surveys, through turnover rates, through stories of what you're facing, boots on the grounds, working with the people that we serve. And so really, what's really important to all of this is that it's going to help us here in Missouri to provide quality services to those that are accessing our waiver services, our state plan services. So thank you all so much for that. And I would also be remiss if I didn't say that it is a lot harder to spend money than it is to cut money. So I also want to thank everyone for just helping us roll out so many initiatives over this next year, and even kind of what we've been doing the last couple of years. So we'll roll through these pretty quick here, but just so everyone knows, we have our new decision items. So the utilization, that's kind of a standard one that we request. So we did receive $127 million, and that included 1,300 slots for in-home services and 402 residential. And this was the first time that we received funding for cost to continue, and that was an additional $38 million for those individuals that we served in fiscal year 21 to help cover some of the increased cost. You know, people are living longer, we're staying in our homes longer, and so costs do increase as we kind of age in place. So again, like I said, that was the first time that we were able to get that. The DD rate standardization, these were funds that were approved originally in fiscal year 22. So it's really just a continuation to keep those rates, and that was for like our residential rates. There was our personal assistant. So that's again just a continuation. The DD telehealth, which is what Station MD is providing, it is now in the waiver, it is the health assessment and coordination service. This funding of $4.4 million was allocated to us, or appropriated to us, to move it from an emergency contract during COVID to a waiver service. So, so that we are moving along on getting that implemented officially in the 1915C waiver. It's approved through Appendix K right now. Okay, on the next slide, we have our value-based payments. And so this was $411 million. $375 million of that is for our rate increases. And that is to bring everyone to all the DSPs to like that $15 an hour. So that was based off of our Mercer rate studies that we've done over the last couple of years. And we were able to get those finalized and then receive funding for that. So we are excited about that. $16 million goes for incentive payments, and those are the value-based payments that we've been working on with stakeholders to implement additional payments outside of just your service payments, to kind of stabilize the workforce, to have some pay for reporting. And then on top of that, we are working on enhancing and well, actually building and then enhancing components of our IT infrastructure. So that is another $19 million. So all of that totals up to the 411. And then we have an additional HCBS enhancements of 14.7 million. This is to build a DD Health Home module in the with Hearst. So a little bit of funding there. It's also to build more around risk mitigation, individual rights, increase in our home modification limits. You're seeing all of those in waiver amendments. We're also looking at, we've sent out a bid request for provider review services, and then also looking at enhancing our medication administration certification. On the next slide, we have more. It doesn't stop there. Case management privatization. We did receive $7.6 million to shift 2,200 individuals from our regional office caseload to private providers, and that would get us to approximately a 1 to 35, 36 ratio. Whereas a lot of our regional offices have anywhere between 1 to 50 up to 1 to 80, 85. So it's pretty high. We received $5.8 million to double our diagnostic evaluation capacity at the six clinics with the autism services. And then there was funding for 2 additional autism centers, $5 million, so Southwest and Joplin. And then DD Council received $17.8 million with their vaccination grant. So we had appropriation authority for that was passed through the budget. And then our community waiver programs, we applied for provider relief funds just like many of our providers did. And we were awarded $3.4 million. So in order for us to be able to spend that, we had to ask for appropriation. So we did get that appropriation. And then finally for me, the fiscal year 23 rate implementation, just a little bit of an update on that. Our rate standardization waiver amendment is under CMS review, and they sent us their first set of questions this week, and our federal programs team is working closely with Fiscal and MoHealthNet to answer those questions from CMS. We also submitted the rate standardization through an Appendix K, and that was to enable us to implement the rates July 1st. And so we did receive questions from CMS on that, I don't know, a week or so ago, and we turned them around the next day. So we're hoping to hear back soon on that Appendix K. That will probably happen a little bit quicker than the actual 1915C amendment. None of the questions that we're getting from CMS right now are concerning. That's mostly clarification. So we'll continue to work on those and maybe update a little bit of the language to make it more clear. Again, I think Wanda talked about this a little bit. For those services that did not need approval, they've been entered in CMOR. Please continue to check kind of those ISL budgets to make sure it looks correct with the RASs, and we'll continue to work through those with the providers. And then tomorrow, just kind of a shout out for everyone. Tomorrow will be our webinar for our rate study refresh, and Mercer, our state's actuaries, will be joining us. And with that, our focus is going to be the refreshing of the wage data. So there's a lot of different components with the rate studies that we have to look at. So the first and the most significant piece would be the wage components. So Mercer will be presenting kind of what we've walked through and talked about with the wage data and how that refresh looks. And then remaining components of the rate study refresh will be in future webinars. So we'll kind of roll those out bit by bit with the providers and the stakeholders. And I think with that is what I have for today. So I'm going to turn it over to Carrie.
Thank you, Angie. Good afternoon, everyone. Today I'm going to be covering just a couple of reminders regarding the verbal signature flexibility and support monitoring guidance. So the division notification was previously sent out regarding the extension of the federal public health emergency. And that renewal was effective for 90 days, or it extended until Thursday, October the 13th of 2022. As a result of that extension, the 1135 and also the Appendix K flexibilities do continue at this time. I know that we do frequently receive questions regarding the verbal signature flexibility. So that's really what we're focusing on today. And just a reminder that the verbal signature flexibility is an 1135 flexibility only, and it will end upon the expiration of the public health emergency. So when the federal public health emergency expires, that 1135 flexibility will expire as well, and there will be no transition period for the verbal signature flexibility at that time. We have included here in the PowerPoint a link to that COVID-19 flexibility chart. And this chart will include the 1135 flexibilities as well as the Appendix K flexibilities. And if you click on the link and go in and view that chart, you will note that the Appendix K flexibilities end no later than 6 months after the federal public health emergency ends. And then if a flexibility is both 1135 and Appendix K authority, then the flexibility will end at the later date. Again, with our focus today on the verbal signature flexibility, that particular flexibility will end when the federal public health emergency expires, since it is an 1135 only flexibility. So that is our review on verbal signature flexibility. And now we're going to move on to some reminders around support monitoring guidance. We have received some questions regarding what to do, currently in cases or situations where an individual or maybe even individuals within a home maybe have confirmed COVID-19 cases. And just wanted to remind everyone that the process is that as that support coordinator is planning for that visit with that individual, the in-person visit, they're assessing and they're determining, does the individual or individuals within that home have a current confirmed COVID-19 infection? Have they been tested and they are awaiting COVID-19 test results, or they're experiencing COVID-19 symptoms? And if any of those things are true, then just a reminder that the support coordinator then would conduct a remote virtual visit, and they would resume that in-person visit after all positive individuals are 10 days past that date of the positive test and they're symptom-free for 24 hours. So just wanted to remind everyone of the guidance that is out there. Also included here is the link. You can go directly to that guidance for your reference. And those are the two updates that I had to share for today. So I will turn it over to our next presenter. Oh, it looks like that is Emily with our Federal Programs Unit.
Thanks, Carrie. Hi, I'm Emily Lubering, Director of the Federal Programs Unit. And I'm going to share some updates or review of the proposed items in our upcoming amendments and our upcoming waiver renewal. Just to kind of go over, we have a amendment currently with CMS, and it's amendments for all 4 waivers. So we have 4 amendments with CMS. We have another one that we're working on, the division is working on for our value-based payments. And then we're also continuing to work on our waiver renewals for Mo Kids in Partnership, which will have the additional amendments to go with them so that all of the items match across all of the proposed changes match across our waivers. So we've got a lot going on, and you'll see when I start going through each of the amendments, keeping track of what's happening when might be a little difficult for everybody, but there'll be communication of the changes. So right now we have the HAC, which is our Health Assessment and Coordination and Rate Standardization Amendment with CMS. This is the one that you hear about, what we're waiting on for CMS to approve so we can do those additional rate increases. So in that amendment, we have proposed adding the Health Assessment and Coordination Service, aka your Station MD, to all of the waivers. We're proposing changing the EAA, which is your Environmental Assistive Adaptive Equipment, and AT, our Assistive Technology, and our Specialized Medical Equipment and Crisis Intervention Services, from a waiver year limit to an ISP year. So no change in the limits, just the change in how they're monitored, how those limits are monitored from the waiver year to an ISP year. We're also updating some of our applied behavior analysis service titles and the standardization of rates. And what that means is we're changing some of our methodology for our services to standardize the rate methodology process. And because of that, we're needing that CMS approval so that we can do those rate increases that we're waiting on. We're also, one of the things that you'll find, most of them are just rate increases. Transportation will be changing from a monthly unit to a trip unit. Because of the maintenance of effort, we will allow both units to be billed according to the provider, their preferences, as not to decrease or restrict any payments or rates at this point. So there'll be more discussion, I'm sure, with Wanda on those changes for our providers as that's implemented. We're also updating the HRSS, which is your Health Risk Screening Tool, implementation date to May of 2024. So complete of the implementation of that, the initial HRSS screening tools will be May of 2024 to kind of coincide with when we've had a full year of connection in place. We're increasing the COMP, the CSW, our Community Support and Partnership for Hope slots. So we'll have additional slots to serve more individuals. And then we're also increasing the community support waiver cap to $40,000. The value-based amendment, that's the additional amendment that we're working on currently. You probably have heard a lot about value-based payments or value-based incentives. The plan is to have this turned into CMS as soon as they approve our rate increase amendment, with an implementation for the items in this amendment starting January 1st of 2023. Of course, this is all dependent on when CMS approves our amendments. In this amendment, we're adding the value-based payments to incentivize and reward for best practices. We're requesting and proposing that we update the environmental accessibility adaptation to home and vehicle modification maximum limit from $10,000 per individual per year to $20,000 per individual every 2 years. So essentially it kind of comes out at being $10,000 each year, but this gives the flexibility to our individuals to have the $20,000 for a 2-year period. And then our last thing that it's proposing is we're going to add the level 2 direct support professional training, completion of the level 2 direct support professional training within a year of employment exception. So they may receive, our DSPs can work towards getting their level 2 training in place of a high school diploma or a GED that we currently require now. And this will open up some doors for some of our DSP workers out there who may not be able to finish their GED for whatever reason, but because they can do this training while they're with their job, they can complete that level 2 training that's in Relias. So the last one that last thing we have going on with our waivers and waiver renewals and amendments is the Partnership for Hope and MoKids waiver renewal. And of course, as I mentioned, we'll also update our comp and CSW with these changes as well. These will be the proposed or the effective date of these would be 7/1 of 2023, because that's when we're due for our renewals of the partnership and MoKids. So in the waiver renewals, we are proposing to make remote supports. We'll move it out of assistive technology and make it its own standalone service. So it will have its own service definition, its own limits, maximum limits, that sort of thing. We'll also add specialized medical equipment maximum limit to the waiver language to match the waiver manual, which is that $10,000 maximum. And that's our current practice. That's in our manual. That's what we follow. We're just, this is more of just adding it to the waiver language. So no actual change in how we practice. We'll be adding virtual delivery for our employment services. So your benefits planning, career planning, supported employment, and I know I'm missing a few, those will be allowed to be provided virtually once approved by CMS. They are currently allowed, as well as other services now under Appendix K, to be provided virtually, but this will allow for them to continue to be provided virtually after the Appendix K expires. We also have some additional updates to our EA service definition, some odds and ends about debris removal, some other things to clarify with the use of that service. And then we'll update shared living limitation to match the waiver manual language. I think it's actually the shared living manual and the shared living staff qualifications. So currently in the shared living, or currently in the waiver, it says parents of minors. We're going to remove the of minors to make it just parents, which this matches what we do in practice as well, and matches the shared living manual. So not really a change there, but making things match across the board. And the last thing I wanted to hit on, so that was a lot of information about all the changes, proposed changes that we have coming. The last thing I want to mention is regarding EVV and the memo field. So if you're not aware yet, or if you haven't heard, electronic visit verification is required for all of our personal assistant visits, SDS and agency, and there are requirements for when those EVV visits are submitted. One of the requirements that we are seeing that our providers are not complying with is the completion of what we're calling the memo field. And that's kind of like an open box where providers are to add a note. And this should relate to what our PA providers would call their progress note. So all of our PA EVV records require a filled in memo field. There is a maximum limit to the memo field. It was recently increased to a maximum of 1,024 characters, including spaces. This is alphanumeric, limited characters, especially some limited characters are allowed. So if a provider goes over the 1,024 characters, the EVV vendor should, it's called truncate, basically determine how much can be sent to the actual aggregator system, which is the Mental Health Net system. If they send over the 1,024 characters, that EVV record will be rejected. So it's important that the EVV system that our providers have can do that function, have that functionality to basically cut off how much they send. We're not asking providers to stop documenting at 1,024 characters. They should have a complete progress note, but their system should only send over 1,024 characters. And any questions that we do sometimes get questions about the documentation requirements, and documentation requirements for PA, the PA service, PA visits have not changed. They need to continue to document the services that they've provided. And then I think that was it. We have sent, you will have seen, possibly seen some emails out there, email blast about this memo field. We're really trying to get providers on board with completing this memo field with meaningful information, progress note information. The MAC, when they do audits, they do not want to see check it in at this time, checked out at this time. They want to see true progress notes. So, and we have been receiving some questions. So if you have those questions, if you're getting questions for providers, please send them our way. And I think that's all I have for today. Thank you.
Hello, everyone. I just have two little agenda items today, and I'm hoping that they are both actually more reminders than brand new information for you. The first item is, as you know, we are working towards transitioning out of the representative payee services. At this time, we don't have a set date as to when we are hoping to be completely removed from this role, but we are actively working on it. I did want to mention, I've gotten quite a few questions about how this process works, and I did want to mention that the process is primarily being driven by Social Security. They are the ones that are kind of working on identifying appropriate individuals or agencies that might be able to serve in this capacity, and then they're getting the ball rolling to initiate those moves. If you do have any questions about any payee moves that have already happened that might be in progress, or if you are interested in possibly becoming a payee yourself or your agency, I would encourage you to reach out to Social Security, and they can answer any questions that you might have about what all is required, and you know, kind of get you started and let you know if you'd be a good fit for that individual or individuals that you are working with. And then the second item, which is kind of goes hand in hand with the representative payee moves. So we will no longer be entering in room and board budgets into Seymour if we are not the individual's payee. Since we aren't making the monthly payments for the room and board side out of the consumer's benefit, the budget's not really driving anything in Seymour. I did want to note, though, that this does mean if you are typically used to printing or receiving your SCL statement monthly, if we are not entering the budget in, this is not going to be populated. So you are going to have to go back to the contracts or another means to look at what the monthly payment amounts will be on those ISLs. I've gotten quite a few questions as we talk more and more about this, specifically about how the group homes would work or how you know how much the rates are for those individuals. And I did want to just remind everyone that that information is embedded into Seymour, and you actually can find it by looking under the provider contract section in Seymour, and it lists out each of those different rates for each of the locations of the group homes. If you aren't sure where to find this information, you can definitely reach out to me or to your vendor support coordinator or any of the other regional business office leads. And that's really all I had today, two very short little items. So please let me know, like I said, if you have any questions on how either of those will work.
All right, good afternoon, everybody. This is Dwayne Shumate, the State Coordinator of Employment and Community Engagement. And I'll be talking just a few minutes about our Certified Direct Support Professional Apprenticeship Program, and then just also a couple of updates about our employment team and the support and service that we're able to provide. So with many of you all have probably heard me talk about Missouri Talent Pathways, which is the name of the effort and initiative that our Certified Direct Support Professional Registered Apprenticeship Program is a part of. So we first started developing Missouri Talent Pathways. It was as early as fall of 2018. So this preceded the pandemic, the understanding of ARPA funds, or any of the impact that we've seen since the public health emergency. We knew at that time that there was an incredible challenge with finding appropriate workforce and then retaining that workforce. So what we began to do was work with a set of stakeholder providers, some family members, some post-secondary ed settings, and really developed an aim of how we could go about helping solve part of the DSP workforce crisis. And as you can see on the screen, the key aims that we had at that time were to stabilize and structure the workforce, construct career pathways for direct support professionals, kind of standardize the priorities and the competencies that we would see of the ideal direct support professional. Anytime you could begin to stabilize the workforce, that's going to mitigate risk, not just risk, financial risk of the provider, but also it will mitigate the risk of any health or safety concerns of those who are receiving services when you're working with individuals that you're more accustomed to, and there's not the ever-evolving door of direct support professionals. And then the last aim that we had was by having greater stability of the workforce with individuals that have possessed national best practice skills and competencies, that this would correlate to increased outcomes for the individuals that we all collectively support and serve. So the key elements of Missouri Talent Pathways, and this is following the U.S. Department of Labor's Office of Apprenticeships guidance on design of a registered apprenticeship. So it is critical. The words registered apprenticeship are critical because that does mean that it has been formally registered, reviewed, and approved by the U.S. Department of Labor. The 5 essential elements that are required in any registered apprenticeship program is that you have to have an employer partner. Those would be our state agency and our community-based organizations. There has to be structured on-the-job training of at least 2,000 hours. And in our program, it is requiring 2,000 hours of on-the-job training and mentoring for any new employee who registers as an apprentice for a community-based organization that chooses to participate in this initiative. Through that structured on-the-job training, direct support professionals will be developing 15 competencies. Those 15 competencies are the evidence-based validated competencies identified by the National Alliance for Direct Support Professionals. In demonstrating those 15 competencies, there are 69 skills that have been identified by NADSP that comprise those 15 competencies. So the 2,000 hours of on-the-job training is focused on mentors and trainings at the mentors and trainers at those community-based organizations, working with the apprentice or new employee on developing these 15 competencies and 69 skills. The third area that's required in a registered apprenticeship program is a minimum of 144 hours of related instruction. In our model, the slide says 169. That's actually been updated to 158 contact hours. So those hours would be completed in the Relias portal, whether you're using the DD portal or if you're with the provider agency that has your own license with Relias. Those 158 hours are courses that parallel with the 15 competencies identified by NADSP. Those are the exact same courses that an individual would be completing if you were participating in the value-based purchasing level 1, level 2, level 3 training. The fourth part that's required in a registered apprenticeship is that the apprentice or employee has an increase in their salary as they develop skills and complete the apprenticeship program. What we have specified in our apprenticeship is that individuals would need to start off at a base wage rate of $15 an hour. And upon completion of the full apprenticeship, they would need to be paid at a minimum of $16.50 an hour. Any employer partner who participates gets to establish their own wage scale. We just need to see that they're comporting to those step increases that I've just covered. And then the fifth piece of a registered apprenticeship is that it results in a national occupation credential. And so what we have done is registered with the U.S. Department of Labor the credential of Certified Direct Support Professional. So someone who is working at an employer partner who chooses to participate, once they've completed the 2,000 hours of on-the-job training, they've demonstrated the 15 competencies and the 69 skills that go along with that, completed the 158 hours of training. Not only would they have a salary increase, but they would also be getting a credential from the U.S. Department of Labor as a certified direct support professional. The 15 competencies that are developed are on the screen here. They fall in 4 broad domains of care, fostering determination, professional growth and development, and then supporting individuals and community integration. I understand the slide's a little bit small, but I know folks will be able to access this presentation later. And so you'll be able to identify those 15 competencies. If you have questions about Missouri Talent Pathways, or if you're a provider agency who would like to have a discussion about it, feel free to give me a call. On this slide, my work email address is listed, as is the MOTAP address. The MOTAP address is also my email. So you can email either one of those addresses and I'll receive it. And then we do have a web page that is hyperlinked on this slide to learn more about it. Currently, we have 8 approved sites across Missouri. We have about 8 other providers that are in the process of completing their applications to participate. We have about 45 other providers who have gone through the initial orientation to look at participating in the registered apprenticeship. Currently, our primary goal is onboarding community-based organizations. We do have currently about 8 apprentices that have already started, but our aspiration is to cross 1,000 direct support professionals over the course of the next 2 years. Okay, leaving the registered apprenticeship program and moving on to our Employment First team. So over the course of the last couple of years, the Department of Mental Health Division of DD has had a contract with the Institute for Community Inclusion. Those staff individuals were predominantly working with provider agencies, developing training and delivering training and technical assistance. But as our employment team has dwindled over the years with some budget cuts and reduction in force, we have now expanded the contract with Institute for Community Inclusion to provide us adequate staffing to meet the same needs that they were meeting through the Employment First Missouri effort, but also now to also encompass the efforts of all of our Employment First specialists previously had as they serve the state. So this staff, they're out there to meet with service providers and targeted case managers. We will be sending out in the very near future flyers of the trainings that they have available, the type of technical assistance that they provide, as well as information about the staff and how to access them. So the ways that they can assist is they can work with regional offices, service providers, and our targeted case management entities to deliver technical assistance by consulting on ways to improve outcomes, ways to better coordinate services, ways to bust myths that may be out there that maybe individuals or families here to kind of help with improving outcomes around employment coordination. They can help in providing technical assistance around best practice in the delivery of services, as well as supporting our regional offices in the development of their QEP plans, and also better understanding the daily life and employment section of some of the monitoring requirements. They do have a full list of trainings that are available. They're also available to do one-to-one mentoring and coaching of staff as needed. And they will also be having regional-based community of practices. So the types of trainings that are available, I've listed here. For support coordination, there's 4 learning pathways. Service providers, there's also 4 learning pathways. But you'll see the topics of training for support coordination is about 11 different topics. and there are 17 different topics of training for our service providers. And moving on to the next slide. Oops, sorry, I clicked. If you would like to connect with members of our employment team, Nick Holtz is serving Albany, Joplin, Kansas City, and Springfield regions. Jesse Kenoy serves Central Missouri, Hannibal, Kirksville, and Rolla. And then Leslie Quarles, who is our newest staff member, is serving the Poplar Bluff, Sykeston, and St. Louis area. Sandy Kaiser is still with us, and what Sandy is doing is kind of working as the lead of this effort and making sure that data integration is occurring, providing technical assistance as needed to Nick, Jesse, and Leslie, and then also filling any gaps of support that may need to occur. And with that, I will turn it over to Lucas and Kim.
Good afternoon, everyone. I'm going to get us started. We're going to talk a little bit about prohibited practices. So I'm going to kind of go over, thanks for that. So I'm going to start with hopefully something that's a review, but if any of these things look strange to you or a surprise, then this would be a good point to notice and to go back to the CSR that covers prohibited practices, which is 9 CSR 45-3.090. It's the behavior supports rule. So I'm going to quickly kind of go through what is prohibited, what are prohibited practices, and then we're going to talk a little bit about some current trends that we've noticed and some issues. So the first page here is really just about the kinds of manual restraints that you can use. So you can't do things where you put people on the floor or against the wall. You can't lay or sit on top of people. We don't allow pain submission holds or things that hyperextend people's joints. And we don't allow anything that's not part of a system that's been approved by the Division of ED. So currently that is nationally recognized physical crisis management systems. Some examples of those are MANT, CPI, PCM, Safety Care. And if you have others that you would like to use, you should let myself or one of the area behavior analysts know, and we can look at that and tell you whether that is approved or not. If you have your own that you want to develop, that is also a possibility, but that has to be reviewed in depth by me and approved. So moving on to the next slide. The other thing that we do not allow are mechanical restraints. So I'm going to kind of summarize the definition in the rule because it's very long, but essentially a mechanical restraint is any device or instrument or physical object that you're using to confine or otherwise limit an individual's freedom of movement that cannot be easily removed by the person. So some examples, so these are just some examples, they're not exhaustive. So there are things that are within this definition that are not specifically listed as an example in the definition. But if you lock a person's wheelchair, specifically if it's a motorized wheelchair and you disable it so the person can't re-enable it, that would be considered a mechanical restraint. Taking somebody's crutches away when they need those to get around, special seat belts, and a wheelchair, for example, that specifically is to keep the person in the chair when they want to leave, not to hold them steady when they're ambulating around, or harnesses that you might be using to hold somebody down in the car or in a seat in the house, or so that they don't run away from you. Those would be considered mechanical restraints. And basically, mechanical restraints are just something that have been prohibited and continue to be prohibited in any HCBS setting that is funded by Medicaid waiver or DMH general revenue. Things that are not mechanical restraints, so these are exceptions. So the medical protective equipment as part of medical treatment for a medical issue. So these would be things like casts after a broken bone or a sling that holds a limb immobile so it can heal. It wouldn't be an arm splint that prevents somebody from hitting themselves in the head. That would be considered a mechanical restraint. An arm splint to help sprained limb or a broken bone heal would be an exception to this definition and not considered a mechanical restraint. As are any other orthopedic devices, so crutches or braces for like knees or wrists, or any of those things that are part of routine medical treatment, medical examination devices aren't considered mechanical restraints, and anything that's used to support functional body posture. So if its purpose is to help somebody sit upright when they can't hold themselves upright, ambulate correctly without falling down, those things are for medical uses and are not considered mechanical restraints. Anything that's used, a typical device used for transportation, such as a seatbelt or a wheelchair tie down. So if somebody has a wheelchair, it's very typical for any person in the community who has a wheelchair to have a tie down in the vehicle to keep the wheelchair from rolling around unsafely. That's what any typical person would experience. That would not be considered a mechanical restraint. And basically just things that help people sit upright or maintain normal posture and balance. Really anything that anybody would do that would exacerbate somebody's medical condition or physical condition, or that is medically contraindicated, would endanger their life, is considered prohibited. So this might include actual what would otherwise be an approvable physical restraint, but somebody who has severely brittle bones, and so it's medically contraindicated to use any sort of physical management technique or a manual hold. That would be prohibited because it endangers a person's life. It puts them at risk of catastrophic bone fractures. Anything that interferes with somebody's breathing or covers a person's face is prohibited. And anytime you're using a restrictive reactive strategy as an as needed or as required basis, so really this is what this is saying is you can't have a standing order for restraint to use it whenever it's necessary. You can have a safety crisis plan that has a comprehensive set of strategies and the criteria for when you should consider them, but you can't say whenever Johnny doesn't do what I want him to do, then you're supposed to manually restrain him and make him do the thing that he's not supposed to do. That would be a prohibited practice. Next slide, please. I just mentioned that one. You can't use punishment or anything that's for staff convenience, or, and this one is a really key one, as a substitute for engagement in active treatment or behavior support services. So what this really says is that in HCBS settings, it's prohibited to use restrictive practices if it's in lieu of active treatment, engagement with the community, or appropriate behavior support services. So just because we would rather use a restrictive intervention, lock up the phone, limit access to the community, any sort of restrictive practice that we would do, and we're not doing that as part of a comprehensive set of strategies to increase independence, teach skills, and work towards not needing that limitation, that would be in lieu of engagement in active treatment and would be considered prohibited as well. And then anytime we're using law enforcement or EDs, emergency departments, as a planned response to a individual specific problem behavior as a way to address it. So what this doesn't mean is that you can't have it doesn't mean that you can't have a provider policy for in an emergency what you would do, which may be to call law enforcement or utilize the emergency room, but it cannot be part of an individual set of strategies. So it can't be the case that anytime Johnny punches somebody in the face that the staff are directed per the plan, per the safety crisis plan, to call the sheriff's department or to take them to the emergency room. If it's a planned thing, then it's not an emergency, and there should be additional strategies that should be being pursued, including other identified or needed services that would help kind of address the reason for that problem behavior from occurring. Next slide. Anytime you're having other people at your agency administer techniques to a person you're supporting, that would be prohibited. So you can't have Johnny's housemate restrain Johnny. That would be a prohibited practice. You can't use corporal punishment, can't use aversive conditioning, can't use you can't use like exercise as a punishment technique. You can't use overcorrection where you make people do something they messed up over and over and over again. You can't put people in totally enclosed cribs or barred enclosures other than cribs. So this one is also really important. We'll see in a minute. Just because it says crib doesn't mean that it has to have metal bars on the outside. If it's a totally enclosed bed, that the person can't leave when they want to, that falls within this definition, and it is a prohibited practice. And any treatment procedure or process prohibited by federal or state law. So if it's illegal to do it in the state of Missouri, or it's illegal in the United States, it's not allowable within the waiver. So that I did this talk probably a year ago, so it's good to refresh folks on what is prohibited in the state. But there's also another reason, and one of the things that we've noticed over the past probably 6 months is that we've just had a huge influx in the number of prohibited practices that we've seen in the state. So I'm going to share some data now. Next slide, please. Actually, I can probably do this. Open. Now I messed it up. Okay, so here's some data from the last 6 years. And what you notice is 2016 had a lot. And if you can remember all the way back then, that was when Directive 4.300, which really was the precursor to the behavioral support CSR that kind of outlined what the prohibited practices were in directive, and also specifically called out seclusion timeout as a prohibited practice if it wasn't pre-approved. And so we had a lot of seclusion timeout happening in the year 2016, and that's where you see the 32. And then after that, we didn't really have that many every year up until 2021, where we've had a ton. And there's a couple reasons why we've had so many in 2021, and why we're on we're on a pace to exceed that in 2022. And one of those is Guideline 85, and Guideline 85, just as a refresher for folks, if you don't remember or you haven't heard about it, it really just outlines what the division will do when we find a prohibited practice. And one of those things is that we will be putting it into IQMFD as a finding that needs to be addressed. And so that's one reason why we think we saw quite a few. But the other thing that happened is we started to come across a lot of medical beds that were being used for behavioral control. And that's where it kind of goes back to that enclosed bed. So there's a lot of devices that have really slick marketing with things like slogans like safety beds, or care beds. And really, when you get down to what their purpose is, it's to keep people from crawling out when you don't want them to. It's to fully enclose them. And while some doctors will recommend those things and prescribe them, and they're very popular in some communities, they're still prohibited in our setting. And as we locate those, we work with teams to identify why it's prohibited and then to fade them out. The other thing that we've noticed is that a lot of use of hospital beds and bed rails as mechanical restraints as well. So, bed rails are supposed to be a support to help somebody not fall out of bed if they move around, but it's not meant to keep somebody in bed when they don't want to be there. So that also can be considered a prohibited practice depending on how it's used. And then the other thing, which is why Kim and I are kind of co-presenting, and we'll probably talk a little bit more about this in the next section, is that even when the hospital beds are there for a medical reason, one of the things we're kind of learning as we look at what the current best practices are for beds is that hospital beds really aren't that safe, and they don't make a lot of sense in a lot of cases. And there's things like entrapment that is a big deal, which is some of the reasons why people end up moving towards these beds that look like big boxes with lids on them. So we have to address those things as we find them, to find an alternative strategy to help the person stay safe, but also to recognize that this is a person who is an adult that should have the same rights that everybody else has, which includes the opportunity to be afforded due process if rights seem to be limited, and that they're extended the same safeguards that anybody else is, including being free of mechanical restraints. So go to the next slide, please. So you'll see, yep, most of them are enclosed beds or inappropriate use of hospital beds. We've had quite a few door locks. That's another one that I didn't mention that it has been considered and will continue to be considered a mechanical restraint. So if you're using a lock on a door for the express purpose of keeping somebody in their home so that they can't leave when they want to, that would be considered a mechanical restraint, because that is a mechanical device. that's not easy to remove, that impedes somebody's ability to move freely around their house and their community. A typical use of a door lock for a house is to keep people out of your home. It's not to keep you in your home. So those things are considered to be prohibited. And when we identify those, we work with teams to identify other options, including appropriate behavioral supports to address the reason for them. We've had a few seclusion timeout. Just as a quick reminder for those, exclusion timeout used to be an approvable strategy if you had pre-approval from me and you had active ongoing behavior services that indicated that it was a need, and there was some pretty sophisticated safety parameters around the use of it. But as of 7/1 last year, 7/1/21, it's fully prohibited, so it cannot be used in any shape, form whatsoever. It cannot be approved at all. So we're glad to not see many of them, but we are concerned anytime we see those. And then the last thing I want to mention about prohibited practices is specifically with kids that have child-specific contracts and reside with one of our providers. So another area that we've noticed is there's been several situations recently where kids who have funding through Children's Division, through a child-specific contract, have these devices as part of some supports that maybe were used by natural family or by schools. And there are providers that are providing services through the child-specific contract that have these things. And we are extremely concerned when we find those. And so even though technically we don't have authority over a child-specific contract because we don't do the funding and we don't have a formal agreement with CD on what to do in those circumstances, we do communicate our extreme concern to Children's Division, specifically the RCSTs, about the dangerousness of such a practice, the use of, say, like a harness or an enclosed bed. And we also communicate that at the moment of this child transitioning over to the waiver, which is almost always the kind of the path for this person, that would be considered prohibited. And so there needs to be some effort. The behavior team is willing to help out to figure out what that effort should be, but there needs to be some effort to get to a point where you don't need that prohibited practice, because at the end of the day, it's going to end up being prohibited. And so typically, what happens is, once we have communication with the RCST and CD, they tend to agree with our perspective on the fact that it shouldn't happen and that it will be prohibited soon. And so they're asking teams to start fading those out as well. So we are just wanting to make sure that people are supported effectively. We don't want people to be in danger. When we do find a prohibited practice, if it's the case that the person can't have the prohibited practice immediately removed because they would be at risk of hurting themselves severely or somebody else, then we will work with the team to fade it out as fast as appropriate. However, even in those circumstances, it's not approved. It cannot be approved. There's nobody that can approve it. It doesn't matter if you have a doctor's order. It doesn't matter if you call the governor's office. There's nobody that can approve it, because we specifically say in the waiver in our CSR that we can't do it. There's no clause in the waiver. There's no clause in the CSR that allows us to make approvals on a case-by-case basis for things that are specifically said to be prohibited. Doing so would jeopardize our federal funding. And we all just heard Angie talk about how much money we were able to get. And so we definitely would not want to jeopardize the ability to continue to get the funding that's allowing us to really up our game as far as provider rates and supporting agencies to be able to deliver best practice care. And I think that's all that I have. So appreciate you all listening to me.
Thanks, Lucas. Good afternoon, everyone. I'm going to touch just real briefly on a reminder that we have some resources available to everyone in relation to ensuring that individuals are afforded due process whenever there's an identified limitation of an individual's rights. Next slide, please. Division Directive 4.200. Appendix C is actually a due process guide. This is a great resource. I've provided the direct link here. It clearly outlines all of the components of due process that need to be walked through when there is an identified limitation of an individual's rights, and it just really serves as a great tool for the individual and for the planning team. This will help you to be able to make sure that all the necessary information is in place to ensure that the individual has been afforded due process, and also to be forwarded to the Due Process Review Committee for that assurance as well. So I just wanted to take a few minutes to remind everyone that that is available and is an excellent resource. Next slide, please. Also, as a quick reminder, and just a quick global reminder, if you are not signed up for the division email blast, please take the time to do so. That's the main primary method of communication that the division has when we want to get information out statewide. This is a good example of that effort. Back in February of 2022, we actually provided some information on some updated trainings through the MoDD content self-registration portal, and they are specific to due process training. We currently have 5 modules available to everyone that cover rights, committee members' roles, chairman facilitator roles, referrals, and an overview for families and individuals. So again, another great resource for individuals and everyone who is part of their interdisciplinary support teams. And also stay tuned, we're continuing to look at ways to enhance and provide technical assistance, coaching, and support to individuals and their teams on this important subject. Next slide, please. Now I'm going to segue into a real quick update tied to Health Risk Screening Tool, or HRST, the Missouri process. I want to thank everyone who has reached out to the division and is currently in the process of onboarding during what we're referring to as Phase 1. Phase 1, as a reminder, is the information and ability to start to implement the process before we go full statewide implementation, which is currently targeted, as Emily mentioned earlier. We're looking at initiating and onboarding close to the connection system go live. So that will be next summer of 2023, with the intent for everyone to be fully screened or have at least one initial screen through the system if you're a waiver participant by the summer of 2024. So looking forward to going into that Phase 2, but currently we are in Phase 1. Greatly appreciate everyone that's reached out. What you're seeing on the screen right now is the division's current webpage for the Missouri DD HRST process. We do have, as noted, a direct email address if you're interested currently and you're a residential service provider or you're a TCM agency who serves individuals receiving non-residential services. Please reach out to us through that mailbox, and we'll be contacting you to get your onboarding process started. And also stay tuned for some email blasts pertaining to some current updates that we're going to be providing for our MoDD HRST process webpage. So thank you again for everyone's interest and participation in the HRST process. And with that, I'm going to turn it over to Leslie DeGroat, who's going to share some information regarding our Observe Decide Act documents.
All right, thank you, Kim, and good afternoon, everyone. I'm glad to be here, and thank you, Wanda, for having me speak today about these informational documents titled Observe Decide Act. I'm going to specifically point out med errors, but you can utilize any of these documents for any kind of educational purposes or training. I'm going to follow that up by also talking about a pilot project related to a mobile dental health unit called Enable Dental. So let's see, I'm going to scroll down here on my, okay, so yes, I will first talk about some informational documents the division created, and as I said, they are Observe Decide Act, and as I said, they cover a different topic. These documents can be used for not only staff to learn from, individuals can benefit from them, families, caregivers, and really the whole purpose of them are to identify early onset of any health issues, any risk factors, and also kind of learn how to prepare and put in some prevention measures and some actions that can help people to stay as healthy as possible. So that is what it looks like on our webpage, and I will drop that web link in chat so that you guys can get to it. Really, you just go under that where it says alerts and updates. There is a whole list, and I can advance the slide actually. There we go. So see, you have this list under here, Healthy Living Observe Decide Act. So we have we decided to go ahead and do the Fatal 5+, which you may have heard of, which those are really common illnesses and health conditions that people with intellectual and developmental disabilities often have. They can be very fatal. So early identification and then putting those supports in place is so important to help people stay as healthy and happy as long as possible. So the Fatal 5, I'll just say them, just tell you what those are. Aspiration, pneumonia, and choking, that covers one. Constipation and bowel obstruction is another one. Dehydration's another. Seizures, sepsis, and then the +1 is gastroesophageal reflux disease, or GERD. So many people have GERD, and it really bothers them, and that poses risk factors in and of itself. So that is another one that was covered and added as the +1. Others that you can see on the list cover burn prevention and safety, flu prevention, incidence and prevention of falls, polypharmacy. We do have different items surrounding COVID, as well as just brand new. We have some, these aren't called Observe Decide Acts, but they are related to COVID. You might have heard of long haul, where you may have residual effects from COVID. And these are just some things that we have seen, and we've worked with our Intellectability, our company that did create the health risk screening tool, and they created the documents. There's one for clinicians, one for families and individuals, and one you can share with staff, just kind of a variety and different links on each of those. So whichever one would suit your needs best, feel free, use any of these documents for education. It's out there on the website. And like I said, I'll put the link in there here in just a minute. I'm going to advance my slide. Oops, went too far. So this is what they currently look like. We're looking to change the appearance of them, maybe make them a little more stylish or eye-catching, but this is what we have so far right now. And medication errors, that is something that if you could solve the issue of med errors, you will be awarded $1 million. I tell you what, that's the age-old question. Especially, we'll talk about the most common here in just a minute. But this Decide Act here, it defines from the National Coordinating Council for Medication Error Reporting and Prevention, basically, simply put, a med error is when a medication is not given to the person whom it was intended, but how it was intended. So, and in our EMT, it's if the medication error, reaches the individual, then that's reportable, as you know. So, about said next slide, and I guess I'm telling myself that. Okay, we can observe the following related to medication errors. We do study the data closely. And this data, we're going to be updating this right here. But according to fiscal year 2019, the most common med error type was administration at 97%. The most common error category was failure to administer at 73%. And the most common error reason was forgot to give at 52%. So this has been the trend for quite some time, that those types of errors. We're currently looking at processes within quality enhancement for the division to more closely monitor these minimal medication errors and reach out when we see patterns and trends. That's something that's in development. And I'm just throwing that out there. Why minimal? Well, as a reminder, any med error has the potential to cause negative outcomes. And we're about prevention and being proactive. We don't want to have to be reactive. We don't want someone to get hurt before, we make a move. We want to keep them from getting hurt. So as you can see, minimal medication errors make up about 98% of medication errors. So what about those 2%? Okay, the moderate and serious medication errors. Moderate is defined as treatment and or intervention other than monitoring or observation has occurred due to the error. Like just an example, like actions were taken to change the outcome. So like if someone gets the wrong medication or too much of a medication and they go to the emergency department and receive IV fluids, they get those IV fluids to help maybe counteract the potential adverse outcome of the meds. So that's considered moderate. You've all had your EMT training, or if not, we actually have that on our Relias platform. So take advantage of that, definitely. Anyway, serious med errors are defined as life-threatening and or permanent adverse consequences, which, I'm knocking on wood, it's scary to think about. These are very rare, but they do, they do happen. The more, and this is just something that's, you just got to know, the more that minimal med errors occur, the more of a chance that a serious med error could occur. So I'll give you a more current data. So this past quarter, fiscal year 22, quarter 4, there were 2,320 medication errors reported across the state. These errors affected 1,393 individuals. So just by those numbers, you can see that many people were the victim of a med error more than once. And so also in fiscal year 22, quarter 4, minimal medication errors still make up around 98% of all med errors. This most current quarter, administration errors were at 95% of the error types, and forgot to give was a little bit up a little bit at 58%, whereas it had been 52%. So they're really not they're not going away. So, but we are monitoring it and trying to put some items in place. And we do have this document here if you want to share it or review it a little bit more closely to kind of help educate your staff or people you work with or whomever it could help, just so they know how important it is to follow their training and the processes outlined. So this page right here, this is the decide aspect of this document, and it tries to get the reader to think about what is causing the error. So it starts off with, what was the error? Why did it happen? What can be done to decrease the likelihood of reoccurrence? The examples of errors could be due to unclear or incorrect physician orders. So maybe the person giving the medications may not be able to understand what the order is supposed to be telling them. I've encountered that before where the doctor just wasn't clear when the order was written. If there was maybe needing to be more planning around medication time and any needed safeguards like making sure that medications, the times were more streamlined, like not giving it several different times during the day. Because if that's the case, people are going to forget, if their medication regimen can be simplified, but that's always a bonus. I also want to highlight there are this is surrounding planning, but maybe if they do forget to take their medications, providing timers to alert when medications are due to be given, or anymore, we have so much assistive technology that's available to make medication administration a task that the individual supported can be used in order to be more independent with their own medication administration and be able to have ownership of that task. As Holly Reif, spoke earlier from the Universal Design to Assistive Technology team, she was talking about that earlier, and it's on our website. You can look at all kinds of different things that are available out there that could help a person with their medication. Let's see, you can see on here many times other reasons for errors is the person who's giving the medications, they just don't follow the procedure as trained. Maybe they're thinking about, oh, we got to go to the grocery store later, this and that and the other, and they may feel rushed. They skip a step and they just don't follow their training, and they made an error. So anyway, this page doesn't have an all-inclusive list of like examples, but it was just kind of trying to get people's minds, flowing and trying to kind of think about when an error occurs. Why? What is that reason, and what can we do to help make that better? Easier for the person being supported and the person supporting that person. Okay, the final aspect of our Observe, Decide, Acts is ACT, and that's like the action piece. This is the action piece of medication errors, and this is working to figure out a person-centered way to prevent them. So individualized strategies that increase a person's involvement and independence is key. This slide shows links to self-administration of medication assessments, and those can be used. They're online, they're available to whomever, and they can be used to determine this person's skill set related to, trying to work towards being more independent and more involved with med administration. This skill set can be built upon as time goes on, and then there's also that assistive technology piece to medication administration this kind of is a long page. So this is the second half of the page. And as I said, I'm going to update it because we have just become a long ways with we're, you know, the assistive technology first state and just more assistive technology that can totally help people with their medication administration. I just can't accentuate that enough. So we have just a wealth of technology approved by waiver funding. Let's see, other methods that I want to point out besides on here, you can see medication home delivery. Now that's something that people can take advantage of so that they can make sure and have their medications delivered on time and maybe at a certain rotation. Some people are able to get text messaging or other messaging whenever prescriptions coming due, so that alerts them so that way they don't run out, because we do see that where a person, they may run out of medications, not get them replaced on time. So there's a med error. Another thing that I really want to highlight, which medication review. So the physician or primary care provider could review the person's medications, and they can determine if all the medications are doing what they're supposed to, making sure that the person has optimum dosage levels, and not duplicated medication types. Sometimes a person will be given a medication and it'll cause a side effect, so they're given a med for that side effect, and they're just, after a while, all these meds are stacked up on this person, they're having to take them all, and then so having a physician or even a pharmacist look over the medications and just make recommendations. I mean, the physician ultimately makes the changes, but just making sure that med list makes sense for that person and really individualizing it. Let's say the person, the best times for them to take their pills is 8 a.m. before they leave the house and maybe 8 p.m. before bed. Well, why not? Why can't the physician make sure that the orders coincide with that? Because that's what that will work best for that person. So let me see, I'll go to the next. Anyway, so please check out this document and others. If you guys ever have any suggestions, we do have a DD mailbox. Please reach out if there's anything that you would like educational documents on, and my team and myself would be glad to research it and give you some tools for training or what have you. So please consider that. We want to help you all out there do the best you can. And now I'll finish up by talking about Enable Dental. This is as you all know, access to dental care is very difficult for the individuals whom we serve. There's currently a program occurring to help decrease this barrier, which I believe can pave the way for the future of people whom we serve and accessing dental care. And there was an email blast that went out about it. And I would like to put that link in the chat to the email blast. And it also has a link for the program flyer and then the consent form. And it's just as easy as filling out that consent form and sending it in to they have an email provided on the flyer. And even if you're not in the counties where they have listed on the flyer that they're providing services, they will take that into consideration and try to serve that person. And now I want to tell you, this is time sensitive. It runs through October. This is the first phase of it, and so they're going to review the data and see how that goes, and continue on from there, hopefully. Last time I heard, they had 77 people signed up for it, and your criteria: a person with intellectual and developmental disabilities. It'll be paid for by Medicaid. Up to 125 people can be served. Okay, so that sounds pretty cool, right? So what else about it, right? Okay, well, this the dental team, a dental hygienist, will go to the home, or perhaps even a day rehabilitation center or wherever. It just depends on where the person feels comfortable, but they'll go to their home, and they will they have a mobile X-ray unit. The dental hygienists, they are specially trained to be able to examine. They utilize teledentistry, so they can really get in there with cameras and look around. There is a dentist that will consult with the different imaging and different things that the specially trained dental hygienist will see. The dental hygienist is able to do cleanings in the home, they're able to do fillings and even extractions. Now the fillings and extractions, they'll bring in the dentist for that, but they're on the flyer. It has a step-by-step process. It lines it out so that, man, all you got to do is the individual or whomever on their behalf sends in that consent form, and then the enabled dental representatives contact them and start doing the planning, and then they figure out what works best for the individual, and they come and see that person and go from there. And you're thinking, boy, this sounds too good to be true. Well, I mean, it's awesome. I see no flaws to it other than just getting signed up, and I'm super tickled about it because it's hard to get out and want to go to the dentist. And so if they're willing to come to your home and provide services, I just think it's fabulous. So if you have any questions or anything, don't hesitate to reach out to our division. I'm going to drop in chat, as I had said, the here I have it on a separate document, but I'm going to drop in chat these links so that you can look at it. You can look at the flyer and kind of decide if that works. And prevention's the key. Maybe a person that you're supporting doesn't necessarily have any dental issues. You know what though? Those preventative, the hygienist going in there and looking and cleaning, before it actually gets to a problem, that is so important for people. We don't want them to have to get to an emergency level of need, because then it just becomes so complicated. Then you run into things like sedation dentistry, which is so complicated to try to get for people. So I hope if you're interested, take advantage of this and reach out to our division if you have questions. I'd be glad to help answer anything, what have you. And so I'm going to show, this is my contact information. So if you can holler at me. Just leslie.degroat@dmh.mo.gov. Any ideas for other observe decide acts, any questions about this enabled dental, health related items, what have you, just reach out. And I appreciate your time today. And I'm going to turn it over to my colleague, Tricia.
Hey, Tricia, I think you're on mute.
Thank you. Mine's going to be short and sweet. As we wrap up the afternoon, we have an upcoming, the 2022 Residential RN Oversight annual webinar. So we're excited that we're going to be holding that. This is kind of the second of its kind. This was previously done at the regional offices. However, when the pandemic hit, this annual meeting for the residential RNs was put on hold. In 2020, we decided to hold this annual meeting virtually. We had a great turnout and success with that format, so we'll be using that format going forward. The purpose of the meeting, thank you for advancing the slide. The purpose of the meeting is to connect the agency RNs with the quality program teams regionally and at the state level. It's also to provide division updates and information sharing. Again, it's virtual. It will be recorded. So we realize that a lot of residential RNs, they're only part-time. So attendance is voluntary, but they can go back and review the recorded video that will be posted on the DMH website. We did that last year for the meeting as well. Our target month is September. We do not have a date set yet. However, there will be an email blast that will come out announcing that date, and it will have instructions for registration. And that's all I have. Thank you. That wraps up our meeting for today. So thank you, everyone, for attending, and thanks to each of our presenters who presented today as well. As Kat mentioned at the beginning of the webinar, the recorded webinar and the PowerPoint presentation, as well as Q&A document, will be available on the DD website. So have a great afternoon, everyone. We will talk with you later. Goodbye.